Right. Hello, everyone. Just want to make sure that you can all hear me first of all. So my name's James Pratt. I'm the Trust Lead for Advanced Clinical Practice here at University of Nottingham Hospitals. And I'm an ACP by background within emergency medicine. I'm joined with Kate Knowles, who's also in the room with me at the moment. She'll be coming on in a bit later. She's the operational lead for advanced clinical practice for the medicine division. We've also brilliantly got Sonia Stone as well on the call as well, which is really useful because she is the director for the ACP MSc at the University of Nottingham. So we'll be able to answer any questions regarding that as well. So just so we can make sure that we can all hear, and we're engaging with what we're going to be talking about. If you could just start off by just telling me what your professional background is, please, and also follow that up as well with what specialty you work within. And if you just all silence your microphones as well, please, while we're doing the presentation. There'll be time at the end for questions.
Hi, my name's Sarah Hollingworth and I've worked in intensive care for 25 years and I'm currently working in cardiac intensive care, but really enjoy general as well. And now I'm going to mute my mic again.
Welcome. So people can try and type in any answers down the side, because I think it might get a bit confusing for you also, but it's nice to hear your voice, Sarah. So Chloe, I don't think there's an issue with sound as far as I can see. She's left. Okay, so we'll make a start on the presentation now. So the presentation will be recorded, okay, just for people to use in the future if they need to use it as a bit of a reference. What I would ask, like I say, if everyone can keep their microphones on silent so we can't get any feedback, and if we just try and keep our cameras turned off as well so we maintain any bandwidth if anyone's got any problems. If there's any questions, we're going to make sure there's time at the end for some questions. So as you go through, if you have questions particularly as we go through, just note David, could you just silence your microphone for me, please? Thank you. So if anyone's got any questions as we go through the session, if you could just note them in the chat at the side. What me and Kate will keep an idea of what they are, and we'll try and answer them as best at the end between myself, Kate and Sonia. So the way that the session is going to be structured, all right, so this is really a session about advanced clinical practitioner roles across Nottingham University hospitals and how we structure it here. We'll be talking about the broader picture about advanced clinical practice and just what that means nationally and how we interpret that locally. There'll be some talk about where we have ACPs across NUH and what specialties they're in currently and where investments are going on for the future. There'll be definitely some stuff around what you need to do if you want to go into a role of an advanced clinical practitioner and what pathways they are into the role across University Hospitals Nottingham. We'll talk about the training pathway and the frameworks which underpin that and some of those governance structures for both the qualified and the trainee ACP and the careers that we have in place for ACPs once qualified as well. So as I say, questions at the end if possible, unless you think I've gone way off track and you want to interrupt me with something, but try and save them to the end and keeping them in the chat, please. So the first thing when we talk about advanced practice is sort of knowing where it sits within the spectrum of healthcare. So there's a lot of work that's been going on around frameworks which underpin levels of practice in healthcare. The most recent one that's been released is probably the advanced practice framework. So what I've put on the slide here, you can see 4 levels of practice. So you've got your novice levels of practice. Now, if you were to put that into sort of professional roles, that would be a registered professional at point of graduation. So this could be a nurse, this could be a physio, this could be an occupational therapist, this could be a paramedic. Once they've been within role, they may undertake some further training within the area in which they work, that specialist area in which they work, which then makes them work at an intermediate level of practice. That's your accomplished sort of band 5 nurse, if we were to put it into nursing. And then there's some work which has been going on nationally of late, looking at enhanced level practice. Now, you could say this is sort of specialist level practice. They tended to call it enhanced on the work they're doing because you could be a specialist within the novice side of things as well. So it's being badged as enhanced practice. And then after that, you've got your advanced level practice, which is what we're going to be mainly talking about today. An advanced level practice is very much about taking that next step. So it's not working in a particular sphere of specialism. It's taking a more generalist approach. And we'll talk about what that actually means nationally. And most recently, there's the consultant framework as well, which is being produced. So you'll see these frameworks being spoken about by Health Education England, and these refer to levels of practice. And it's important when we think about levels of practice that often is different from role titles. So this is the ACP framework, which came out from HEE in 2017, and it's a multi-professional framework. So it's a framework which covers all registered healthcare professionals. So this is healthcare professionals who could be registered to the HCPC, it could be NMC registered. It also could be applied to some voluntary registers we see with healthcare scientists, and that's probably what we're going to see in some of the later releases of this framework. It doesn't talk about advanced clinical practitioners. It talks about advanced clinical practice at a level of practice. And that's important to keep in your mind because it's very different than advanced clinical practitioner as a role. So just to keep that into some sort of perspective, if you have a advanced endoscopy nurse specialist, that's a nurse, we have them in this trust, who undertake endoscopies, they run endoscopy lists, they work at a very, very advanced level, and they work across the pillars of advanced practice. But it is it's a specialist area, so they are advanced in a single specialist area, which is slightly different from other things like the advanced clinical practitioner role, which may be underpinned by a generic job description. So the way that this is defined nationally is, so ACP defined nationally is that they define it as that you need to be a registered healthcare practitioner. So currently this wouldn't include areas such as physicians associates. This may change in the future. And it's associated with a level of practice characterized by a high degree of autonomy and complex decision making. So this, when we apply it practically to what we're doing, this could be that endoscopy nurse, advanced nurse specialist. This could be the advanced physiotherapist working in a shoulder clinic who's putting that high degree of autonomy and making complex decisions. What's really key here, it's not just about the clinical practice, it's what underpins that level of clinical practice from an academic award, and that's having an underpinning master's level award or equivalent. And this has to be a relevant master's that encompasses the 4 pillars of advanced clinical practice. And that is clinical practice, leadership and management, education and research. So this is where it stands out a little bit. So ACP roles, okay, or people working at advanced level practice need to ensure that their job includes these 4 pillars of advanced practice, which is, like I say, clinical practice, leadership and management, education and research. And then the delivery of that in their role has to be underpinned by appropriate training. Now, the next sentence is probably the bit I like most about this definition. So they need to be able to demonstrate against a set of core capabilities and also area-specific clinical competence. So HEE have come up with a set of core capabilities, across those 4 pillars of advanced practice. They are very broad because they need to encompass everyone. So they need to encompass our learning disability advanced clinical practitioners, just as much as they need to encompass our advanced critical care practitioners. But what's key, as well as having those core capabilities and that core generic set of competency, you also need to have your specific clinical competence. And we'll talk about how we've adopted this across NUH and how it looks for us at NUH. So regionally, we've taken this process and we have come up with a set of core competencies as well, which are more professional competencies across these 4 pillars. So there's a various different sets of frameworks and competencies which underpin the role of advanced clinical practice. But what's important to take away from what I've just said is HEE have defined this as a level of practice. Kate's going to talk about how we define ACP in the trust in a mo. It's underpinned by master's level award, and you have to be mapping your role across the 4 pillars of advanced clinical practice. It may be that you have more of a greater role in one of those pillars than the other, but you should be demonstrating capability across the pillars. So I'm going to pass you over to Kate now, who is going to talk a little bit more about the role of ACP. So just give me a second while we try and do this smoothly. So if you turn on the camera.
I think I should be on. Hi there, folks. I'm Kate Knowles, and James very kindly introduced me a little bit earlier. This is advanced clinical practice at NUH. We've got a picture here of Queen's. NUH is both Queen's and City, and Nottingham University Hospital is really lucky to be closely affiliated with its local universities as well. So advanced clinical practice at NUH involves a lot of people and a lot of organisations. What does it mean to be at NUH as an ACP? Well, it means that as a trainee, we are recruited into trainee posts, and we are working on a recognised master's degree that's generic across NUH. It used to be, when we first started this several years ago, 10 plus years ago, that we were actually all a little bit different in the way that we trained. Now at NUH, we're very proud to say that actually all trainees are working on the same curriculum using the same framework, and we share learning and development as trainees. And as qualified ACPs, we take that further. It means that we have trained as an ACP with a relevant master's in advanced clinical practice. We have clinical and professional evidence in our portfolios, which have been huge, great paper exercises, and hopefully might be electronic in the near future. But certainly the trainees coming through now have got electronic portfolios, and we'll talk about that in a bit. And it means also that we're working across all 4 pillars of advanced clinical practice, both clinically and in our development time, where we have continuing professional development time, which again we'll talk about in a bit. So we now have an astonishing 130 trainees and qualified ACPs at NUH. I find this just a little bit mind-blowing because it doesn't seem that long ago when it was actually only probably 30. That's possibly as time speeds on as I'm getting older. But James and I were just talking a little bit earlier that it was actually probably only 5 years ago when we were covering ACPs maybe just across 5 specialties. And now, because it's been such a successful training programme and the ACP role in itself has just proven itself to be so superb, we are now covering 16 specialities, and there are more, hopefully, that are going to come on in the next few years. And what we're looking at now is we're not just looking at those specialties in their own right, we're actually looking at potentially a flexible workforce for the future. and how can we enable ACPs to be working not just in one area, but just in maybe in a few areas. So this is very exciting. The way that people become ACPs is probably best identified by these 3 doors, in the fact that there are 3 ways in which people have become ACPs over the years. And historically, the first door was that there were lots of people who were working as ACPs but had done their own training. They were already very well established ACPs, but they were working clinically as ACPs, and with just maybe a little bit of extra training, they are ACPs as we know them now, but with a different type of training program. The middle door, second door, is people who are potentially in very advanced specialist roles, who have got a lot of training by background, but now they've identified that actually they'd like a little bit extra and they would like to become advanced clinical practitioners, and they access the programme in a slightly different way to the third door, which is the more traditional approach, where we recruit people as trainees from a variety of backgrounds now across the healthcare professionals, and they are employed as trainees. They go on the generic standardised training programme and they become ACPs at the end of those 3 years. This slide is a beautiful slide in the fact it shows how people come from a variety of backgrounds. And here we've got the 4 pillars that are actually beautifully showed both before and after training as an advanced clinical practitioner. So ACP, once qualified, isn't actually the ceiling, and it's even more exciting into potentially where you can go further on down the line. So look at this beautiful clinical career pathway. It means that you can be working bedside clinically with your patients, but then you can actually go down the more specialist routes of the pathways of education, leadership and research in the future. This is just a good opportunity to explain how we've changed from the advanced nurse practitioner at NUH to advanced clinical practitioner, as HEE have helped guide us, in the fact that I think it was probably 4 years ago where all our ACPs were nurses, and now we've got, I think, 10 who are physios on the training pathway, and 2 of which are going to qualify this year. So it's good stuff. And most importantly, here we just need to explain that this is where we need to make sure that people come in and access the training pathway, or ACPs, with the generic skill set that we're asking. So a lot of healthcare professionals have got that background of professional registered bodies where they can continue to upskill, and physios, pharmacists are good examples where a professional body can support them in the, for instance, non-medical prescribing advanced skill set, whereas there are other healthcare professionals where they haven't got that background that supports them in that, and that's where we are actually finding some stumbling blocks. And I think that's over to you now, James.
More on the personal specs.
Oh yeah. In terms of the personal specs, the personal spec for coming in as a trainee, this is important to actually just bear in mind, in the fact that as well as being on a current register with a professional body like the NMC or the HCPC, it's important that people come in with a degree, evidence of a degree of at least 2-2. And now the background of the training is now apprenticeship, or many ways it's apprenticeship. We're also asking for level 2 maths and English, and that's purely because of the apprenticeship pathway that's UK based. I think that's probably it.
Hello again. So I think now we've just gone through what ACP looks like nationally, what we see it as locally. Just on top of that 130 ACPs that we have, we also have about 400 members of staff who are working at advanced level practice roles who could map to the HEE framework. When Kate was talking about the role of ACP, it's the role which is underpinned by that generic job description, that generic training framework. So what we're going to do now is just talk through how that training pathway looks, what underpins it, and how it all works, really. So the first thing is I'll give you a bit of an overview of the whole training pathway, and then we'll talk about the years in detail. So as Kate said, we run this as an apprenticeship alongside the University of Nottingham. The course, which was written in partnership with the University of Nottingham, was the first in the country. We were the first to pilot it. All of our current year one trainee ACPs are apprentices, and all of our about eight of our year two ACPs are apprentices. So formally, how we used to do that was fund it through an HEE framework, which we don't need to worry about anymore if taking the adult pathway. Currently with paediatrics, it's a slightly different training pathway. But it is a 3-year apprenticeship pathway, which has a few different elements to it. It has the work-based learning element, and which is then linked to the supervision element. And then it's also got the academic side of things as well, which is delivered by the University of Nottingham. And some of the clinical skills are delivered in partnership with the Department of Research and Education downstairs in the emergency department. So if we go through each of the years one by one. So first of all, year one. So before you can even undertake the Masters in Advanced Clinical Practice at Nottingham University Hospitals, you need to make sure that you have a job as a trainee ACP. This is not just, oh, I want to go and do a master's program in advanced clinical practice, so I'm going to sign up for it and access apprenticeship funds. There's so much more that needs to be in place to make this work. So we have a shared business model across the whole trust about how we train our ACPs to ensure that there is equality across divisions and specialties in how we release our staff and the time they're released, making sure that there is the correct amount of supernumerary time at the right periods of training, making sure there is shared learning throughout, and making sure there is resource supervision throughout the training pathway as well. So if you are successful in getting a trainee ACP post at Nottingham University Hospitals, we will ensure that the resources are there for you to undertake the pathway. So the end point will be your graduation as an ACP. So year one, and I'm going to talk about this quite generically. So Kate's already talked about the sort of general personal spec. The majority of ACPs who are recruited within areas in which they already have a specialist interest in. That's not saying that's exclusive, but generally a critical care practitioner will have a background in critical care if they're applying for those posts. So year one is structured between 2 modules, one of 40 credits, one of 20 credits. They are both very much based around examination techniques, the consultation and history taking, and also around anatomy, physiology and decision making. So I'm going to talk about how that looks pre-COVID, because we don't know exactly sure how that is going to look post-COVID. So pre-COVID, the way this worked was that you would be released as a trainee ACP for 15 hours a week, 7.5 hours you would go to the university every Thursday, where in the morning you would undertake normally anatomy and physiology or something else which is knowledge based, where you would have completed the workbooks around anatomy, physiology, pathophysiology before attending. You would then move to a skills session in the afternoon, which in module 1 would either be history taking, cardiorespiratory examination, gastrointestinal examination, acutely unwell patient assessment and management, the mental health history, frailty examination. So lots and lots of stuff. The way that they're structured in the afternoon is that you would go between round about 6 stations where we have a simulated patient in each. We try not to use mannequins. We don't use mannequins pre-COVID. And you would rotate around the stations where you would have some sort of peer supporting you, which is either a senior ACP from the trust or from the region, or a consultant or a teaching fellow who would give you direct feedback. That would then happen throughout the whole of year one. The assessments that would be undertaken would be OSCEs. So you'd have OSCE assessments, an assignment in module 1 on clinical decision making, and you'd also have MCQs on anatomy and physiology. So the banding at this point varies depending on the role in which you will undertake. So if you're 15 hours, so we release you for 15 hours, 7.5 hours, as we say, is for university. The other 7.5 hours is for you to be supported within your workplace. And that differs from specialties to specialty. We don't say what has to happen. So some areas we use that as shadow shift. Some areas we use it for preparation for university. It varies, but there is time allocated to it. Most are recruited at a band 6. This is a training pathway with a guaranteed band 8A. Ones who are recruited at a band 7, and the difference there is that in the other 22.5 hours, these are generally full-time jobs. The other 22.5 hours, you contribute to the professional role within which you work. So give an example of that. If I am a band 7 nurse on acute medicine, and I get recruited into a trainee ACP post, I may well be recruited as a band 7 because I will be using my 22.5 hours offset still being whatever a band 7 does in acute medicine, and the other 15 hours would be within my training. And you could do that for a band 6 or so on. We do ask that you have band 6 experience as part of the personal spec. That is really, really important. We can train everyone, I pretty much feel, to be able to work clinically at a level, but it's the other pillars of advanced practice and having experience in leadership, management, education, which really helps you become a rounded ACP. So that's year one, lasting for about 10 months in total. Also included in this is you will have three monthly tripartite meetings, which is where the university will be represented, where your manager, employer will be represented, and you will as well. And that's where you would have a discussion about how you're progressing. This is part of the apprenticeship. You would also keep a learning log as well to show that you're having 20% of your time as off-the-job training, which is your university time and the other 7.5 hours. So when you pass year one and you pass all the assessments, you then move into year two. Year two is where it becomes really exciting for me. So this is about 10 months into your training, and then you become completely supernumerary. So this is the expensive part of training. So we pay for a post to freeze, and we also pay for you. So you do not contribute to any rota at this point. So there's no rotas that you're contributed to, and you're not expected to contribute to rotas. Your time is your time. But this time is about you meeting the competencies which are set. So if we go all the way back to the start of the talk, we talked about the national capabilities. So within year two, there's a couple of modules. One of them is the work-based learning module. We start that early in year two. And what's in there, and I'll try and demonstrate the portfolio at the end for you. It reflects what those capabilities are from a national perspective, but they also reflect the NUH generic clinical competency framework, which is divided between symptoms, conditions, investigations, and procedures. So, for example, we would expect every single ACP to be able to take a history around a patient who presented with a symptom in, let's say, the cardiorespiratory system or from a gastrointestinal symptom. And we'd also expect our ACPs to be able to have a generic plan and be able to manage, say, a condition such as angina, for example. And we'd also expect you to probably be able to undertake an ECG and have some basic ECG interpretation skills. They are generic competencies. Now, let's put that, though, around specialist competencies. Let's say that I am a respiratory ACP. Well, everyone's got pneumonia, for example, on their competency framework, but the respiratory ACP will probably have that broken down a little bit more and probably have Legionnaires, etc., because their competencies are around their specialist practice as well. So another example being there would be if you took the emergency department. So everyone would have, I don't know, they would have fracture, they would have limb fracture, for example. Now, if you work in ED or you work in trauma orthopedics, You're not going to have limb fracture. You're probably going to have fracture of the hand, fracture of the wrist, fracture of the lower arm, fracture of the upper arm. You might have dislocation. So you then have specialist competencies built on top of that. There is various sets of national frameworks of specialist competencies which are accessed within specialties as well. For example, RChem have a set. There's a frailty set. There's a set for learning disabilities. There's a set for critical care linked to Royal Colleges. But the important bit is year 2 is about you developing as an individual and also meeting the gaps which may be there from a professional background. So what we found with our physios, for example, compared to a nurse, our physios are brilliant at making decisions and working autonomously because it's something they do day in, day out in the roles which came up with, and taking histories, for example. But what I neglected in my thoughts was around administration of medications, for example, and prescribing, because that's something which is very foreign to them. So professionally, you also need to address your competencies. So year 2 is made up, like I say, of the work-based learning module, which has a few assessed parts as well, which one part is your portfolio, which you would evidence and you'd get signed off to. But you'd also have 3 written elements to it as well, where one of them is deliver an interprofessional education session and write a reflection, lead an audit and reflect on the leadership of that audit, and also write a situational analysis. During your training and your work-based learning, you will have consultant supervision time. So every ACP across the trust gets funded 1 hour consultant supervision time. Now that varies in the amount. That's the minimal which we would ask for. Once your Viva's complete, once your work-based learning is completed and you've also completed your academic elements, you undertake something called a Viva. A Viva is a general assessment of your clinical competence and a review of your portfolio. It is not formative, okay? It's your endpoint assessment, all right? So it's a summative assessment. During year 2 as well, you also undertake your non-medical prescribing. If you've already got non-medical prescribing, as many nurses, AHPs have, then you do not need to undertake that module, and there would not be another module for you to undertake if you're an apprentice. So once you've completed your non-medical prescribing, which happens about midway through, and you've done half of your portfolio, you would move on to a band 7. All right, so we've done a band 6 in year 1 for the majority. We move to a band 7 once you've done your non-medical prescribing and you've completed about 40 to 50% of your portfolio. It's defined. Then at the end of year 2, actually it's about year 2 and 2 months, you undertake your Viva. Once you've completed, we'll go back to e-portfolio. Once you've completed your Viva, you then move on to working on rotas. Now that rota may be a medical rota and you may join at SHO level. It may be that you join at registrar level. It depends on the area in which you work. It may be that you don't join a medical rota at all and it's a whole new role and a whole new rota that's being set up for a service which previously may have been covered by medicine, or it may be based on growth or some sort of intervention we've done to improve a patient pathway. ACPs generally across the trust get a 3-month period at this point where they transition to practice. So you're not supernumerary, but you're what we say is supervisory. So you're working with a lot more supervision. And then after about 6 months roundabout, you then undertake your final thing, which is your transition to practice and your endpoint assessment, which depends if you're doing it through the apprenticeship route, which the majority of people are, which is an open book exam and also a presentation with questioning. You then get an 8A and you will then finish your training as an ACP. But you'll see the entire pathway has been created over the last sort of 10 to 15 years. 15 years ago, we had ACPs who were undertaking a Master in Advanced Clinical Practice in their own time, whilst working full time. And that included in year 2 whilst trying to provide evidence and meet their competencies. But we've listened to staff and we've tried to create a framework which works across the divisions. So once you've qualified, where do you actually sit in the trust? So this is an example of our governance structure. Now, depending on which division you're in, depends on how established this structure is. So if you take the medicine division, this is how the medicine division is set up currently. Other areas such as the surgery division, who are new to ACPs, are slowly starting to build these models. But this is the governance structure which we've signed up to across the trust. So you'll see in, I don't know what colour we'll call that, sort of a pinky colour, you'll see you've got the trainee ACP there, which is a band 6 and a band 7. And then you can see next to it, you've got a buddy ACP. So every trainee ACP has a buddy who supports them. So that is normally a qualified ACP, but it sometimes is a senior trainee ACP within that area. So ACPs are banded at band 8A generally. Recently, we've just having a case going through looking at senior specialty ACPs who will be put in different areas across the trust. These ACPs are moving further on to registrar rotas, but the majority are 8As. So the trainee ACP also has that consultant supervisor who currently is a medic in the trust, although we're looking at this being ACPs as well. This is someone who is your educational supervisor who support you both in being your sign-off of your competencies, but also to support you in your development across those other pillars of advanced practice. Most areas then have a lead ACP. Areas where the numbers are small will have a nominated lead. So this is an ACP who's been nominated within the team who will take on the operational management of that ACP team. And there's a set of roles and responsibilities. They're supported by a similar role, which is a consultant specialty lead for ACP. This is a really, really important role because what this role does is it supports our ACP teams, giving them a louder voice within medicine, really, to make sure that their voice is being heard, to fight those battles around radiology and things like that, which are easier than they ever were because we have a trust-wide approach. But still, when you're setting up areas, you need to have that medical buy-in. Areas where there is no nominated lead. So if we were to take oncology, for example, where we've got 2 ACPs training, they're both in year 2. Well, they're being managed operationally by their specialty matron with support from myself as trust lead ACP. Some divisions are looking at putting in specialty lead 8Bs. So an example of that would be the emergency department where there's 44 ACPs. So they need to have some bigger leadership there. They would also take on the leadership around the other practitioner roles. Medicine, because 88 of our ACPs are based in the medicine division, we have an operational lead ACP, which is Kate Knowles, who's in here with me. And then Kate then sits just under the divisional lead nurse. And so there is a pathway from trainee ACP all the way up to trust board of where a voice for ACPs, which has taken us a long time to establish. But you can see there is a governance structure there, and also aside to this, there's assurance structures as well around prescribing, around radiology, around DNA CPRs, all of those other things around referrals, around accessing different specialties. I could go on forever, as you can see. We have 2 forums set up here which meet monthly. So we have the ACP forum, which is where all nominated leads and all professional leads from the trust meet, and that's to really drive the agenda of ACP strategically and to make sure that what we're implementing has a voice. That goes to the Nursing and Midwifery Board and will also answer to the AHP board once it's restarted for final sign-off of anything that's made at that point. That's because that forum has become really, really important for us. And we'll be releasing our 5-year ACP strategy in the next 2 or 3 months, which has come from the ACP forum and the trainee ACP forum, which is, we don't like to put too much pressure on our trainee ACPs because, as you can see, there's a lot of work to be done in year 1 to 3, but we want to ensure their voice is being heard to make sure that our training frameworks are suitable for them and that they've got a chance to say if there's any concerns or if there's any way we can work things out better. So an example being, Kate has brilliantly set up a year 2 monthly training day for our year 2 ACPs, which is mapped to some of those generic competencies, which has been really, really good. So both of those meet monthly currently. All qualified ACPs get something called continued professional development. Now, what that is time off the job to develop themselves professionally across the 4 pillars of advanced practice, and that's written within contracts. So an ACP who works at NUH will get 6 hours a week continued professional development. What's expected in that time is 2 hours of it is about service development and about improving the area in which they work, improving networks, patient pathways. The other 4 hours is about their development. Now, that development might be around any one of those pillars of advanced clinical practice. So it may be that they want to explore the pillar of education and want to assist Sonia in delivering some elements of the ACP masters. Maybe they want to get into leadership. Maybe they want to do research studies. But what we do expect is that every ACP does cover every single pillar of advanced clinical practice to the level in which they're working. And we're defining that across the trust at the moment. So a year one ACP who's qualified, what would we expect them to have met under each of those pillars? And all the way up to sort of year 3, 4, 5 qualified. But then what does that career pathway look like for that ACP? Because there's plenty of career pathways for our ACPs that we've seen emerging across the trust. And you'll have come across ACPs working in some of these senior roles. So we showed you earlier some of those leadership management posts. So I never thought 10 years ago when I started training as an ACP that there'd be a trust lead ACP role for me, or there'd be divisional lead roles or specialty lead roles. We've had ACPs move into posts such as heads of service, taking on leadership roles within their specialties in the departments which they work. We've got ACPs who are delivering education, who have undertaken masters in medical education, who are writing curriculums for local universities, who are supporting the delivery of education programs. We've got ACPs working in partnership with other areas of education. But education is a really powerful thing for ACPs because we really do sort of sit between allied health professionals, nursing and medicine and sort of bridge that gap. We've seen ACPs really push the boundary clinically. So when it all first started, it was all very much you'd make a referral and the doctor would say, oh, when will I get to speak to the doctor and things. Now we've got ACPs who are leading clinical areas, working nearly up to consultant levels and up to consultant level in certain areas as well. And that's been really exciting. And that's now being recognised in some of those posts that we've been looking at in the specialty lead posts. And then there's research, audit, innovation, and we've seen so many good projects come out around research, innovation and change. We've really seen that across the pandemic, and that we've seen some ACPs really lead areas, lead things in education, in research pieces, in audit, in publications. We've seen ACPs step into resilience roles. It's really been quite exciting. I think the point is ACP isn't just about seeing patients and working clinically. That can be, it crosses all of the pillars of advanced practice. And the way I see it in the future is if we just look at those senior ACP roles that we've looked at already, we're giving them 25% non-clinical time versus the 16% we're giving to a ACP at 8A, meaning that we can start to job plan them around what their specialist interests are, which is really quite exciting. So really what I'm getting at is career pathways are endless for ACPs. They really are endless. We don't know what it will be. We don't know how it will look. And we have an opportunity with this emerging workforce to really shape the future at NUH. We're really lucky as a trust in that we have a trust which is bought into ACP and is willing to support ACP. And we're really seeing now services which the clinical services are so reliant on those services that if those services weren't there, we would not be able to deliver what we deliver day to day as a trust. So we're becoming reliant on these ACP roles, and then that's filtering into other specialties and other divisions who are slower to catch on. But we're way ahead of the picture nationally, and it's important for us to recognise that. And it's important then to us to be thinking about what are the next steps for ACPs at NUH. And I'm hoping the strategy will really pull that along. So I'll get off my passionate thing about ACPs then. I can go on a bit. So we are going to just have a think now. I know there's been a few questions coming through already, which we'll work our way through, but just have a think if there's any questions that you'd like to ask at all around ACP pathways at NUH or just generically about ACPs in the region. Sonia, did you want to just come in while they're just asking some questions and bits and add anything at all that you'd like to from a university perspective?
Thanks, James. Hi, everyone. My name's Sonia Stone. I'm the course director for ACP at the university, as James said.
You're there, Sonia.
I'm here. Can you see me and hear me okay?
Let me see if I can see you. Let me see if I can unmute you, because I may have muted you. Oh, no, you're unmuted. I just can't hear you.
I can hear you.
Oh, can you? It's just me then. Oh, I can hear you now, Sonia.
There you are. Okay, so thanks for inviting me along. And James introduced me earlier on, but I'm the course director for ACP at the University of Nottingham. Background is as an ACP in critical care, so clinically that's where my interests lie. I think you've really outlined everything about the course, James, really well. There's nothing really for me to add from a university perspective as in what we deliver. There are some questions in the chat that I've been sort of following as we go that I might be able to pick up and answer as we go. But if there's anything specific you want to know about a university Masters in Advanced Clinical Practice or anything that I can help with specifically, then pop the questions in there and I'll answer them as best I can.
Okay, so if we just start running through the questions. Yep, let's just start with the top one then. So the first question is, if you already have a completed MSc and certain modules of that could map across, is there an RPL available? Do you want to answer that, Sonia, about how that fits within apprenticeship programs?
Absolutely. So the apprenticeship works slightly differently to what we might call the usual student route that you would normally apply to the university, and we go through a slightly different admissions process for that. As part of that application, you would be expected to fill in what we call an initial needs assessment, and it would be at that point that you tell us the education that you've already undertaken and at what level, and if you feel that it maps against the outcomes and those sort of key outcomes for the apprenticeship. And if it maps to the point that we feel that you've already achieved that, then we can look at bringing in some of those credits from those modules you've done before. The thing about an apprenticeship is that the apprenticeship levy is the funding aspect of the apprenticeship that says that we can't use that funding to repeat learning. So if you've already covered something in modules that you've done previously, we can't use that funding to teach you the same things again. So it may be that there is a process that we can RPL things in, or it may be that we can make you exempt from certain aspects of the programme if you've already covered it, but it would be on an individual basis through that initial needs assessment.
Yeah, and I think that's in the important point when we've had this before, where last year we were doing some initial needs assessments. It's really difficult because the modules are so specific to the role of an advanced clinical practitioner. Unless you have a module like non-medical prescribing, which easily maps across, or you have a very in-depth clinical skills module, because I will say we do clinical skills better than most in the country, then we need to make sure that they're in place as well from a governance point of view, from a trust. So it sort of works in a couple of different ways when we do those things. Sonia, do you want to just, there's another question here about non-medical prescribing. So, and the question is, does there need to be a top up if non-medical prescribing was done at degree level? Okay, so you, in terms of generally, when you want to take a master's degree, you can bring in credits of a certain number that were done at level 6 without having to do a top up. The difficulty is it's always around how many credits you obtained from your non-medical prescribing module. Each university packages non-medical prescribing slightly differently, and some will offer it at 40 credits, some at 30 credits, and that's where the difficulty lies when you bring that in. So again, it would be looked at individually, but you wouldn't be, if you've already done NMP, you wouldn't need to do it again, regardless of whether it was at level 6 or level 7. Because it's a professional qualification that sits on your professional register. So we would never expect for you to repeat it. It would just be a matter of looking at those credits and how many you've got at level 6
because there are various rules that sit within the university quality manual that say you can only bring this amount of level 6 credit. So if it sits outside that, that's something that I have to explore on an individual basis again. But generally, you don't need to top up and you don't need to do NMP again.
Thank you, Sonia. So just a couple more questions which we'll go through. So Kate will answer these. So Kate, what is the process for recruiting a trainee ACP and who interviews?
So this is, I'm echoing with James. So this is all related to the business case. So this is why it's really imperative that the business cases, the business plans, the planning for all of that, areas in which they are planning to have ACPs in the future, and this is probably going on to the renal question as well, that was put forward, is that everything is done centrally, because what we're trying to do is trying to make sure that everybody is prepared the same way. Everybody knows the person spec and the requirements to become ACPs. And we're aiming that all of the ACPs who are employed, and it relates absolutely to this year's business plan that has the financial backing for each of these posts. When we get the okay from that business case, that is James's joy of joys of doing, we can then advertise and recruit. And what we are aiming to do is, rather than have lots of silos of lots of people recruiting in various different interviews and lots of different teams all over the place, which we've done before, we're trying to do one interview day. And who interviews on that day will actually obviously depend on James says him, but it actually depends on who's available at that time. So it would be a consultant, it would be the ACPs, it would be the lead ACPs that would be interviewing. It would also be patient representatives, and as many people involved at the same time in one go. So I think that answers that question. Now.
Yeah, so then just following on from that, are there any plans to introduce ACPs into the renal department?
So at the moment, there are no plans to bring ACPs into the renal department. I think if it's something that you guys, as the team, the workforce within the renal department, feel that ACP could work really, really well, you need to work in conjunction with your consultants, your head of service, your business managers, and you need to start talking to James about this. It's too late for this year, but in the future, why not?
So I know certainly there's been conversation of renal in the past. Whenever you think about an ACP, you have to think about where they're going to sit within the patient pathway, because we just talked you through the training pathway and you can see how expensive that is. You've got to pay, I mean, it's over £100,000 to train every ACP, and I mean, it's way over that. So to give you an idea, for the business case we've got at the moment for 45 ACPs, it's £6.1 million to train that many. So it's an incredibly expensive job to do. So what you have to work out is where the cost saving will come in the future. So whether that's based on growth, whether that's based on locum save maybe, whether it's based on quality, but that's the way you have to approach it. And that's where your specialty managers will be able to help within renals under CAS. So if you speak to a specialty manager, because they've been really good around some of the other ACP cases we've written with CAS, but it's thinking about where it will sit within the department. Kate, another question. Who line manages the ACPs once qualified?
So the line manager is the nominate. So each group in each specialty will have a nominated lead. So the nominated lead for that team will manage the ACPs once qualified. In areas where there are just two of them, that's a little bit more tricky. And I think James alluded to that a little bit earlier. But where you've got a group of 5, for instance, you'll have one person who is the nominated lead, and then in that division you will have an operational lead, and they will be line managed that way.
So I'll just run through some of the questions a bit quicker down the side then. So does working as a cardiac research nurse at Band 6 count towards years of cardiology experience required for ACP? Yes. I mean, you have experience within the specialty, and working at a Band 6, you have Band 6 experience. It's not just being a clinical Band 6. That doesn't, it's about, and this is the beauty of ACP. You can come at it from all different angles. And then you can, then once you get your CPD time, you can then start thinking, actually, I need to really develop myself from a leadership point of view. Or actually, what you want to be is an ACP with a clinical academic interest. I mean, it's endless, really. So yes, of course. So how have we overcome OTs developing into this role and the barriers around non-medical prescribing? So nationally, this is a massive problem, and it is across the patch, in that we've got physicians associates who can't prescribe, we've got ODPs who can't prescribe, we've got OTs, lots and lots of different staff groups. And nationally, they're trying to reduce the amount of registers which are out there and to make them more voluntary. I think what has to happen is there has to be some recognition of non-medical prescribing, not as base profession, but as profession you're going into, and around a voluntary register from that point of view. So, for example, physios can do non-medical prescribing, but a physio can't administer an IV benzodiazepine. So then how do you appoint a physio into the emergency department who could be looking after patients who could be having seizures? How do we appoint them into critical care if they can't necessarily do sedation? So it becomes difficult, and then you end up having to do lots and lots of PGDs to workarounds to get around this. Now, we are one of many, many trusts highlighting this nationally, and I think it will progress at pace. The way that it has been overcome, and the way that the university can help support this, is that there is ways of doing prescriber ready courses. Is that right, Sonia? So yeah, so I don't know if you want to just explain what they are, Sonia.
Yeah, so we have options for individuals who at this present time aren't able to become a non-medical prescriber, and that is that we've created some, as James describes it, sort of prescribing ready type courses. So they will be specific to whatever your base profession was and the constraints that those base professions are facing at this present time around prescribing. So you will learn about the principles of prescribing, of safe prescribing, of pharmacology. You just won't obtain the license to prescribe at the end of it, with the view that then when those restrictions are lifted, or we get in a position whereby, for example, OTs are able to prescribe, you'll have completed a module giving you that underpinning knowledge that we would then just need to top up to give you the competencies to be able to prescribe. Thank you.
So yes, I think that's key. And actually, some ACP roles, the prescribing is actually quite minimal to the role. And a lot of the time you can get around it with PGDs and things like that. It's just whether you can use PGDs as well. But there is plans in place, so don't let it put you off. When the roles are advertised, come and speak to the people within those areas. If you do not have a degree but evidence of study at level 3, is there a pathway into training without one? So this needs to be looked at on an individual basis, and we have a look at it, and we look at what the roles are, and we look at what the level of your training is and what training you've had as well.
I think that.
Yeah, I'm going to throw into that one. So just want to talk what Matthew's put a message in here about. I have an MSc, an MA, and just finishing a PhD. So we've had people come through this pathway as well. So the academic element might be master's level, but this is, in some ways, the majority of this role is not the academic side of things. It's about the clinical skills and the clinical competencies which underpin the role. So what we would do is, as Sonia explained earlier, we would look at what your academic pathway has been, and then we would look at how the apprenticeship would fit into that. And now it's about what your master's is in, and it's looking again at individuals. All right. So the problem is that, as I said earlier, when you look at the program, it is all clinical. So unless you've got a master's which covers all of those examination skills, all of those clinical competencies, non-medical prescribing, then actually they're all relevant. Now, what level you do them at is the academic. We can, clearly, Paul, I can see that you can study at that level, but this is more about the clinical skill side of things, about whether we should actually even manage this in-house in the trust. lots of different ways that we could do it, but once again would be on individuals. So do all specialties mean night shifts as a qualified ACP? Well, it depends on the specialty. Some ACPs will work on 24-hour rotas. ED, we're working towards that with acute medicine, working towards that with frailty, working towards it with ACCP, anywhere which provides a 24-hour service, really. Where you might not see that happen so much is maybe oncology and places like that, where they tend to cover more of the clinic side of things. But it depends on where the role will sit, really. But yes, they all could do. When will we know about the business case? Well, we're out of time now, so we are actually out of time though, but I will carry on. But feel free, if you need to leave, okay? So from a business case perspective, so the business case is from an NUH side of things, it is gone through the first side of things last week. It needs more work because the problem is, because of COVID, NHSI nationally have said you cannot invest in anything, all right? So you can't spend more money unless it's COVID related. Everything has to be paid within this year's financial envelope. So what that means is, for the year 2 part, where it costs millions and millions, we need to pay for it ourselves. The only way you can pay for things like that yourself is to do job freezes or to suspend services, which is what we don't want to do. So we're looking at more novel ways of how we can fund year 2 and bits. One thing that is playing to our advantage here from an adult perspective is we are hoping that that intake will be not September this year, but will be in January with the University of Nottingham, which will really help because it gives us a bit more time to think. That doesn't mean I'm just resting on my laurels with those, Sonia. We will make it get through. More questions?
I would say we've covered all questions, folks.
So I don't know if you heard Kate then, but I think we may have covered all questions. There's one that I'm working on becoming an ACP is worth applying for a trainee post in another area, or should I just? So it'd be good to try and sort out within your business case, ideally for the area in which you work. That would be the most ideal thing, because you're passionate about your area and you want to develop your area, and we can help support that. Some areas will never be able to develop ACPs because they just don't need them, because there is enough staffing there currently and the pathways don't suit it. And then that's maybe when you want to look at other ACP areas, okay, where you may want to work. Yep, so just Kate just wanted to quickly say something.
Sorry, I think something that's important in answering your question is, what is it that you want to do? Do you really want to specialise in renal? And is that where your heart is? And you've got to think about what you're going to be leaving the house, skipping, excited about to do. Is it about renal nursing, renal work, or is it about being an ACP? And we are here. So to anybody out there, all 3 of us who've joined in this, whether it's through the university or whether it's through medicine or whether it's through NUH, we're all available to talk to you on an individual basis to help you decide this kind of thing and give you a little bit of guidance.
Brilliant. So we will tie it up now, okay? So thank you everyone for coming. And as Kate just said, any advice needed, interested in roles and things, come and have a chat with us. There is a couple of other resources on the EEE intranet page, which you can also access if you're not from the trust, and that is, there is a apprenticeship video which explains the apprenticeship a bit more, which I did with Ruth Pierce a few years back, it must be about a year or 2 back, which just describes the process a bit more. There's also a podcast on there, I believe, from the Take Orally website, which looks at how we set up an ACP service in the emergency department. But if any of you want to explore career and advanced practice, come and chat to us. We're, as you can see, incredibly passionate about it, and yeah, we're here to support you. Okay, so thank you all very much. Have a lovely day, and thank you for joining us. Take care.